Artificial Intelligence Doctor, www.abcpharma.net/English. User question. In patients with pre-existing cardiac conditions such as left bundle branch block, LBBB, how do subtle differences in apical lead placement influence the efficacy of pacing therapy in reducing or exacerbating dyssynchrony and subsequent heart failure progression? Google AI Studio answer. That's a very important question that highlights the complexity of pacing therapy in patients with pre-existing cardiac conditions like LBBB. Here's a breakdown of how subtle differences in apical lead placement can impact dyssynchrony and heart failure progression. Electrical activation. Patterns. Optimal placement. The ideal apical lead placement aims to achieve synchronized ventricular activation, where both ventricles contract almost simultaneously, minimizing dyssynchrony. Subtle shifts. Even small changes in lead position can alter the electrical pathway, leading to subtle variations in the timing of ventricular activation. Dysfunctional pacing. If the lead is slightly off-center or positioned in an area with less favorable electrical conduction, it can result in delayed activation of the left ventricle, exacerbating dyssynchrony. Impact on dyssynchrony. Increased dyssynchrony. Suboptimal lead placement can worsen dyssynchrony, leading to a wider QRS complex on the ECG, poorer ventricular function, and increased symptoms of heart failure. Reduced efficacy. Pacing therapy may be less effective in reducing dyssynchrony if the lead is not optimally positioned, potentially limiting its benefits in improving heart function and symptoms. Long-term effects on remodeling, heart failure progression. Ongoing dyssynchrony due to suboptimal lead placement can contribute to detrimental ventricular remodeling, where the heart structure and function deteriorate over time, worsening heart failure. Increased mortality. Dyssynchrony and remodeling are associated with an increased risk of adverse events like heart failure exacerbations, arrhythmias, and increased mortality in patients with LBBB. Factors influencing lead placement sensitivity. Left ventricular anatomy. The size, shape, and individual anatomical variations in the left ventricle can influence how subtle lead placement shifts affect electrical activation patterns. Severity of LBBB. Patients with more severe LBBB might be more susceptible to the effects of suboptimal lead placement, leading to a greater degree of dyssynchrony. Pacing mode. Certain pacing modes, like VVI, might be more sensitive to lead placement variations compared to DDD modes, which can adjust pacing parameters based on the heart's natural rhythm. Conclusion. Subtle differences in apical lead placement can have a significant impact on the efficacy of pacing therapy in patients with LBBB. Optimizing lead placement to achieve synchronized ventricular activation is crucial for maximizing the benefits of pacing, minimizing dyssynchrony, and reducing the risk of heart failure progression. Careful planning, advanced imaging, and meticulous implantation techniques are essential for achieving optimal lead placement and ensuring successful pacing outcomes in these complex patients.